Supplements are sold as health boosters. But here's a twist after 60. 5 common ones might raise heart risk. I'm Drew Mercer, founder of AgeStrong, and I care about this because my dad's heart scare at 70 shook me. I teamed up with a geriatric PT and a cardiology RN. We dug into the science, not the ads. Here's what we found. Older adults use a lot of pills. In one long-running cohort, most older women used at least one supplement by 2004. Many used several, and heart disease remains the top cause of death after 60. So what we choose to swallow matters. This video walks through 5 popular supplements often taken for heart health or general wellness. We'll look at fish oil, iron, calcium, vitamin E, and niacin, not to scare you, to inform you. Some trials and meta-analyses suggest risks like irregular heart rhythm, blood pressure swings, clots, or even higher death rates. A large review in 2021 reported that omega-3 pills at higher doses were linked with about a 25% rise in atrial fibrillation. Atrial fibrillation means an irregular, often rapid heartbeat. It can raise stroke risk. That is not a small note at the bottom of the label. You and I want clear answers. Here is my promise. I will name the journals. I will speak in plain words. I will not tell you what to stop. I will give you strong questions to bring to your clinician. Have you ever assumed a supplement is 100% safe? If so, you are not alone. Stay with me. We'll resolve one myth at a time and keep the pacing slow and calm. First up in our countdown, fish oil. Why would a good fat ever make a heartbeat stumble? Let's unpack it now. Quick safety guide before we dive in. This is education, not medical advice. Your body, your history, your meds, and your lab results matter. Never start or stop a supplement or prescription without talking to your clinician. If you have heart disease, atrial fibrillation, a pacemaker, heart failure, kidney disease, liver disease, or you take blood thinners, antiplatelet drugs, blood pressure meds, diabetes meds, or statins, you need a personalized plan. That plan protects you from interactions and dosing mistakes. I'll define terms as we go. Atrial fibrillation, or AFib, means the top chambers of the heart beat irregularly. Blood can pool and clot. Oxidative stress means reactive molecules called free radicals damage cells. All-cause mortality means deaths from any reason, not just one disease. I walk at a slower teaching pace on purpose. Breathe with me. Pause the video when you want to jot notes. Save this to review with your family or caregiver later. What you will hear today comes from respected journals and large trials. We are not guessing. We are testing claims against data. You deserve options, not fear. I will show you safer ways to think about dose, timing, and why age changes the picture. We will cover seated, simple actions you can take today, like making a clean medication list and setting a doctor visit. We will not push products. We will not demonize them either. All right, with guardrails in place, let's start the countdown. At number 5, the crowd favorite, omega-3 fish oil. The story is more complicated than the label makes it sound. Here's how I built this episode. I pulled findings from peer-reviewed high-quality sources. That means randomized trials, meta-analyses, and large cohort studies. We leaned on journals like Circulation, the BMJ, the Lancet, Cochrane reviews, and long-term cohort data such as the Iowa Women's Health Study. I looked for patterns, not one-off headlines. If a result shows up in multiple solid studies, it deserves attention. If big trials disagree, I will tell you both sides and why that might be. For omega-3, a 2021 meta-analysis in Circulation pooled over 80,000 adults. Average age was mid-60s. It found more atrial fibrillation with marine omega-3 supplements, especially at higher doses. For iron, lab science shows how excess iron can drive oxidative stress. Cohort data in older women linked long-term iron supplements with higher mortality. For calcium, an analysis published in the BMJ raised concern for heart attacks with calcium pills, while a later collaboration found no clear increase. That means the topic is debated. For vitamin E, Cochrane and other meta-analyses found no heart benefit. For niacin, in high-risk patients on statins, 2 landmark trials found no added protection and more side effects. I share this so you know the backbone of what's coming. These are not stories I heard at the gym. They are large, careful tests. Our job is to apply them to life after 60 with care and context. With that, let's begin the list. At number 5, omega-3 fish oil. At number 5, we have omega-3 fish oil. Fish oil sounds heart-friendly, I know. I used to say the same. However, when researchers gave higher doses, more people developed atrial fibrillation. That's an irregular heartbeat that can raise stroke risk. A meta-analysis in 2021 published in Circulation pooled over 81,000 adults around age 65. It found about a 25% higher risk of atrial fibrillation with marine omega-3 supplements compared to placebo. The signal grew with dose. In trials using more than 1 gram per day, the hazard was higher. One analysis showed roughly an 11% rise in atrial fibrillation for each extra gram per day. Here's another twist. In a large trial using 4 grams per day of purified EPA, major cardiac events dropped, but hospitalizations for atrial fibrillation rose from about 2% to about 3%. Benefit and risk lived in the same bottle. Lower dose trials around 1 gram per day, like Vital, did not show the same atrial fibrillation jump. That suggests a threshold effect. Above it, the heart's electrical system may be nudged in the wrong direction. Why might this happen? Omega-3s change cell membranes. At very high levels, that change might alter how electrical signals travel across the atria. The dose also matters because many supplements are not standardized. One capsule can vary in EPA and DHA content, and some oils oxidize with time. Oxidized oil can irritate vessels. The takeaway here is simple. Dose matters. History matters. If you have palpitations, atrial fibrillation, or a pacemaker, your care team needs to review your omega-3 plan and your exact dose. Stay with me. Still at number 5, let's make dose crystal clear. Still at number 5, let's talk dose. Many of us think more is better. With omega-3s, the story is not that simple. Meta-regression across trials showed something important. With each additional gram per day of marine omega-3, atrial fibrillation risk edged up by roughly 11%. That is a dose-response pattern. In plain words, higher dose, higher rhythm risk. Trials using about 1 gram per day often showed no rise in atrial fibrillation. Above that, several studies did. That tells me we need precision, not guesses, not handfuls of capsules. Labels can confuse. Total oil per capsule is not the same as EPA plus DHA. One soft gel might say 1,000 milligrams of fish oil, but only deliver 300 milligrams of EPA and DHA. Another bottle may be concentrated. Some products sit in warm warehouses and oxidize. Oxidation means the oil goes rancid. Rancid oil can be pro-inflammatory. That is the opposite of the goal. If you and your clinician decide omega-3 is right for you, talk about form, dose, size, and the specific reason. Is it for triglycerides, for general health, for a prior heart event? Medical-grade products used in trials are not the same as random discount brands. Also, if you already have atrial fibrillation or you feel flutters, that deserves extra caution. I've coached many seniors who felt proud of taking fish oil. Pride is good, precision is better. Bring your bottle to your next visit. Ask for the dose your doctor meant, not the dose the label implies. Up next, number 4, in our countdown, iron. At number 4, we have iron. Iron carries oxygen in your blood. It keeps you from true iron deficiency anemia, but too much iron is a spark. Biochemists describe a reaction where excess iron helps make reactive oxygen species. Those are highly reactive molecules. They damage fats and cell membranes. They nick DNA. They stress mitochondria, the cell powerhouses, and the heart has a lot of mitochondria. Over years, this can age blood vessels faster. That process is called oxidative stress. Epidemiology lines up with the lab science. The Iowa Women's Health Study followed tens of thousands of older women for decades. Supplemental iron use was linked with a higher risk of death from any cause, about 10% higher than non-users. Iron had one of the strongest links among the vitamins and minerals studied. That does not prove cause, but it raises a bright flag, especially for well-nourished seniors. Here's the context I see in clinic. Many older men and postmenopausal women are not iron deficient. Some already carry higher iron stores. Adding daily iron on top of that can push levels too high. That is a quiet problem. You feel nothing until trouble shows up as blood pressure issues, heart strain, or other organ stress. On the flip side, real iron deficiency needs treatment. The key is testing first. Ask your clinician about simple labs like hemoglobin, ferritin, and transferrin saturation. Those show your iron story. If you need iron, you take the right dose for the right time. If you do not need it, you skip it. That is the safest path in later life. Moving on, number 3, calcium pills. At number 3, we have calcium pills. The promise is strong bones. The concern is the heart. Several trials and analyses suggest that calcium tablets with or without vitamin D may increase heart attack risk in older adults. One reanalysis published in the BMJ in 2011 found about a 21 to 24% higher relative risk of heart attack for women on calcium plus vitamin D compared with placebo. A pooled analysis across 8 trials, totaling tens of thousands of women, reported a similar signal. The combined risk for heart attack and stroke was also modestly higher. Why could that be? One idea is the bolus effect. A bolus is a large, sudden dose. Tablets can spike blood calcium for a few hours. That may upset delicate processes in blood vessels and promote clot formation in susceptible people. Over time, repeated spikes might encourage calcium to deposit where we do not want it, like artery walls. Now, we must be fair. Not all studies agree. A later collaboration that pooled many participants found no significant increase in coronary heart disease with calcium supplements in older women. That tells me there is debate. Still, the earlier signals are not noise. When data conflict, we weigh benefits and risks. For a senior with heart disease, atrial issues, or kidney disease, the calculus may shift. I've coached clients who took calcium because that's what you do at 60. After we reviewed diet, many discovered they already met most needs through food. Pills became a backup plan, not a daily habit. Still at number 3, let's set the context on food versus pills. Still at number 3, let's put calcium in context. Food is not a tablet. Dairy, leafy greens, and fortified foods deliver calcium in the smaller, steadier amounts. Your body absorbs those differently. The harm signals we just discussed come from studies of pills, often at 500 milligrams or more per dose, sometimes twice daily. That means a bolus. Diet does not hit your system like that. A large pooled analysis published a few years after the BMJ paper found no clear increase in coronary heart disease from calcium supplements with or without vitamin D. That gives some reassurance, but it does not erase earlier concerns. When evidence is mixed, age and history should steer you. If you have kidney stones or chronic kidney disease, you already know calcium needs careful management. For heart disease or diabetes, it's the same lesson. Slow, steady, and supervised beats sporadic high spikes. My coaching rule is simple. Food first when you can. If a clinician tells you a supplement is still needed, clarify the smallest effective dose and timing. Split doses may reduce the bolus effect. Check whether your diet, including fortified foods, already covers the gap. Remember, more tablets do not equal stronger bones if the heart pays the price. We are halfway through the list. We've covered omega-3, iron, and calcium tablets. 2 more to go. Number 2 is a classic antioxidant with big promises that did not stand up in trials. Let's talk about vitamin E. At number 2, we have vitamin E. For years, vitamin E was sold as a shield for the heart. The idea made sense in labs. Antioxidants mop up free radicals, but large human trials did not show a heart benefit. A major review of randomized trials found no significant reduction in heart attacks, strokes, or deaths with vitamin E supplementation. The pooled risk for death from any cause was essentially unchanged. Other meta-analyses echoed the same point across doses from low to very high. Why the mismatch? Biology in a dish is not the same as a human system with complex feedback loops. In real people, antioxidants can sometimes blunt helpful signals. They can also interact with blood thinners and other drugs. When trials across tens of thousands of participants show no heart benefit, the burden of proof shifts. There is no strong reason to take vitamin E for heart protection in later life. I remember a client who felt vitamin E gave him an edge. We compared that belief with the trial tables. He shook his head and said, "I bought a story." He didn't feel bad about it. He felt informed. That's the win. The lesson is clear. Save your money for things that work for you. If a clinician has you on vitamin E for a rare reason, that is a different conversation. For heart outcomes, the evidence says it doesn't help. Up next, number 1. It raises HDL, the so-called good cholesterol, yet it failed to prevent events. Niacin. At number 1, we have niacin, also called vitamin B3. Niacin raises HDL cholesterol. Years ago, we hoped that would cut heart attacks and strokes. Then the big randomized trials arrived. In high-risk patients already on statins, adding niacin did not lower major cardiovascular events. One trial was halted early for futility. Another, with more than 25,000 participants around age 64, showed no drop in heart attacks or strokes when niacin was added. Worse, The niacin groups had more serious side effects. People developed new-onset diabetes more often. There were more infections. There were more problems with muscle symptoms. This taught a hard lesson. Raising HDL with a pill is not the same as improving outcomes. HDL is a marker, not a magic lever. If you are on a statin and your clinician mentions niacin, it is fair to ask, what benefit are we expecting? The landmark trials say there was no added benefit in similar patients, and the risk of harm was higher. I've seen older adults flush bright red on niacin. The flush feels hot and uncomfortable, but the unseen risks, glucose issues, bleeding risks, drug interactions, are the bigger concern, especially after 60 with multiple meds at play. Extra side effects can push people into a dangerous spiral. We've finished the countdown. 5 popular supplements, 5 caution flags for the heart after 60. Let's zoom out. Why do these risks tend to rise with age? The answer helps you make smarter choices with your care team. Take a breath with me. That was a lot. You did great to stick with it. We just covered the 5 items in our countdown. The key thread is dose, age, and context. Your heart is not a lab chart. It is a living pump with a history. Pills act differently in that story. If you're finding this helpful and you want calm, evidence-based guidance for life after 60, consider subscribing. We post new videos on a steady schedule, paced for real learning. And if you want to support the work, share this with someone who oversees medications for a parent or spouse. We learn together here on AgeStrong. Back to the plan. In the next few minutes, I'll explain why aging changes how your body handles pills. Then I'll cover quality control, common myths, real-world interactions, and the exact steps to talk with your clinician. My goal isn't to sell you a belief. My goal is to give you tools. Tools turn fear into action. Grab your list of supplements and prescriptions. If you don't have one, start a simple sheet of paper with names and doses. Keep it handy. We'll use it soon. Ready? Let's talk about aging and why the same dose at 40 can act very differently at 70. After 60, your body changes, metabolism slows. That means you clear drugs and nutrients more slowly. Kidneys and liver, the body's filters, have less reserve. A normal dose at 40 can accumulate at 70. Body water is lower, body fat is higher. That shifts how fat-soluble vitamins and oils like vitamin E and fish oil distribute and linger. The heart itself changes. Older atria can be more irritable electrically. That makes atrial fibrillation easier to trigger. A small nudge can become a big event. Most older adults also take more medications. That's called polypharmacy. Each new pill adds a chance of an interaction. For example, high-dose vitamin E can increase bleeding risk when combined with blood thinners. Niacin can worsen glucose control in someone already fighting blood sugar swings. Calcium tablets can bind other meds in the gut and change how they work. Iron can do the same. On top of that, many seniors have silent atherosclerosis. Arteries are stiffer. Pressure waves are different. A sudden spike in blood calcium from a tablet can hit those stiffer pipes harder. The system can't buffer surges as well. All of this does not mean you must fear supplements. It means you should personalize them. This is why I slow the pace in these videos. We breathe, we check the basics, and we move with intention. In a moment, I'll explain why. Supplements are not regulated like drugs, and how that affects purity and dosing. Then we'll bust a few myths and map out your next steps. Supplements are not regulated like prescription drugs. In the United States, manufacturers must ensure safety, but they do not have to prove effectiveness before selling a product. That creates gaps. Labels may show total oil but not clear EPA and DHA amounts. Batches vary. Some fish oils may oxidize during storage. Oxidized oils can smell fishy and may irritate tissues. Calcium pills can contain binders that slow or change absorption. Iron tablets can cause gut upset and interact with other medications taken near them. Another quiet issue is contamination and mislabeling. From time to time, regulators send warning letters to companies for adulterated or mislabeled products. That shakes trust. You can lower risk by choosing products that carry third-party testing seals like USP verification, and by buying from companies that publish assays. That does not guarantee perfection. It just raises the bar. One more point. Supplements and prescriptions can collide. High-dose vitamin E may raise bleeding risk with anticoagulants. Niacin can interact with statins and increase muscle side effects. Fish oil at high doses can affect bleeding time, which matters before surgery. Calcium and iron can block absorption of thyroid pills and certain antibiotics if taken together. Timing matters. This is why I ask you to bring your full list to your clinician. We want to see the whole picture at once, not one bottle at a time. Next, let's bust a few myths that keep us stuck in old habits. Myth 1, natural means harmless. Reality, natural substances can help and they can harm. Marine omega-3 supplements in higher doses were tied to more atrial fibrillation in older adults. Calcium tablets have been linked in some trials to more heart attacks. Niacin raised HDL, yet did not cut events and caused more side effects in high-risk patients. Natural does not equal risk-free. Myth 2, all antioxidants protect the heart. Reality, vitamin E was tested in tens of thousands of people. Large reviews found no reduction in heart attacks or deaths. Some analyses even hinted at slight harm at high doses. Lab theory did not turn into clinical benefit. Myth 3, adding one more vitamin always helps. Reality, in a big cohort of older women, long-term iron supplement use was linked to higher mortality. More pills did not equal more years. The body likes balance, not excess. These myths are sticky because they promise a simple fix. I get it. When my dad fell and lost confidence, I wanted a magic answer too. What actually worked was measured change, steady routines, and careful review of every pill he took. That is slower than clickbait. It's also safer. You now have a clearer lens. Next, let's look at common interactions and red flags so you know when to pause and call your clinician. Here are red flags I watch for with older hearts. If you have atrial fibrillation or feel heart flutters, be cautious with high-dose omega-3 supplements. Review dose and purpose with your cardiology team. If you have diabetes or prediabetes, be careful with niacin. It can worsen glucose control. If you're on blood thinners or antiplatelet drugs, ask before taking high-dose vitamin E. Bleeding risk may rise. If you have heart disease, kidney disease, or a history of kidney stones, discuss calcium tablets carefully. Spike doses can complicate things. If you take thyroid medicine, antibiotics, or osteoporosis drugs, separate them from calcium or iron by the time your prescriber recommends. Those minerals can block absorption. Another red flag is stacking pills. People often take a multivitamin, then add single ingredient products like vitamin E or iron. Overlap can push totals too high. The label on one bottle does not know what the other bottle is doing. Write everything down. Timing can be a problem too. Taking several supplements with morning prescriptions can lead to unpredictable peaks. Spacing doses can reduce clashes. Your clinician can help set a simple schedule. If you feel new palpitations, chest discomfort, shortness of breath, severe headache, black stools, or unusual bruising, seek medical care right away. Do not wait for a video to answer a symptom. Up next, I'll give you a calm, step-by-step way to talk with your clinician about your supplement list without feeling rushed or judged. Here's a simple script you can use at your next visit. Step 1. Bring every bottle, prescriptions, supplements, powders, and drops. Put them in a bag. Step 2. Bring a written list with daily doses and the times. Include brand names if you can and why you take each one. Step 3. Share your goals. For example, I want to protect my heart and avoid extra side effects. Clear goals help your clinician guide you. Step 4. Ask for priorities. Which supplements are needed now? Which are optional? Which should be paused until we check labs? Labs might include ferritin for iron status, lipids for heart risk, and creatinine for kidney function. Step 5. Confirm timing. Ask for a simple daily schedule that separates minerals from sensitive meds. Step 6. Clarify. Stop rules. What symptoms or lab changes should make you stop a product and call? I often add one more step. Agree on a date to review the list again, usually in 3 to 6 months. That keeps momentum without pressure. Take a photo of your plan so you can share it with family. You are not being a difficult patient, you are being a partner. Clinicians appreciate complete information and clear questions. Coming up, I'll recap the 5 supplements we covered, the heart-related risks noted in studies, and the single next step to take today. Quick recap of the 5. Number 5, omega-3 fish oil. Higher doses linked to more atrial fibrillation in older adults with dose-response signals. Some trials at 1 gram per day did not show this, but higher doses did. Number 4, iron. Essential when deficient, but excess can drive oxidative stress, and long-term supplemental use in older women was linked with higher mortality. Number 3, calcium tablets. Some analyses showed more heart attacks and a modest rise in combined heart attack and stroke, while later work found no clear increase. Food sources are a different story. Number 2, vitamin E. Randomized trials did not find heart protection across a wide dose range. Number 1, niacin added to statins, no added heart benefit, and more adverse effects in high-risk patients. Common thread. After 60, dose, interactions, and organ reserve matter. More is not always better. Use lab testing to confirm need, especially with iron. Consider the difference between food and pill with calcium. Be cautious with high-dose omega-3, particularly if you have rhythm issues. Respect the lack of benefit for vitamin E in heart outcomes. Reconsider niacin if you're already on a statin. Your next step today: make a complete list of everything you take, with doses and times. Put it in your wallet or phone. Schedule a medication and supplement review with your clinician. We created a printable checklist with questions to ask. The link is below. In a moment, I'll wrap this up with a final reminder and a respectful challenge to carry into your next appointment. We dug into research today, but remember, this information supports, not replaces, your medical care. You deserve a plan built for your body and your goals. The big idea is simple. 5 popular supplements can affect older hearts in ways most people don't expect. Omega-3 at higher doses raised atrial fibrillation risk in pooled trials. Excess iron can fuel oxidative damage, and long-term supplemental use was linked to higher mortality in older women. Some analyses tied calcium tablets to more heart events. Vitamin E did not reduce heart risk. Niacin added to statins failed to help and increase side effects. Use this knowledge to take action. Make your list. Book a med review, download the checklist below, and bring it with you. You are in charge of your questions, and that power matters. If this style of calm, evidence-based guidance helps you, subscribe for future videos and share this with someone who cares for a parent or partner. New episodes arrive on a steady schedule, and we keep learning with you. Standard note before we go: this channel is for education. It is not medical advice. Do not start or stop supplements or medications without your clinician's guidance. Thanks for watching and spending this time with me. What will you ask your clinician about today?